I have been in the field for a long time and revisiting what has been happening over more than 4 decades. There's a lot, but to point out a few things, I think, which is only sort of a tangential answer, but I think what has been most important is a tremendous collaboration in this field. Otherwise, we wouldn't be today where we are, I will say. I think a very important medical technical aspect has been the development of tissue typing, HLA typing, of course, in an effort to identify donors for transplantation, if you allow me to focus on transplantation rather than immunosuppressive therapy. But certainly immunosuppressive therapy has been important, the development of ATG and in various preparations, which even though people anticipated that this old-fashioned approach would die a sudden death when the monoclonal antibodies came along, that has not been the case, still being widely used. I think then certainly the improvement of conditioning regimens, how patients are being prepared, because in the early parts, in the early times of transplantation, failure of engraftment or rejection, if you wish, was a major issue. Patients had been sensitized by receiving a lot of blood transfusions before coming to transplantation, and so the body didn't accept the transplant. So that has been overcome by various conditioning strategies. Then the prevention of graft versus host disease, this undesired attack of donor cells against the patient, and again in the setting of transplantation. I will make an additional comment on the other strategies, and that has improved considerably over at least the last couple of decades. And then certainly the move from using not only matched family donors, but also using unrelated volunteer donors and using what we call HLA haploidentical donors. In other areas, certainly I mentioned already ADG, then the addition of L-Thrombopac, other blocking agents that have been very useful in patients who may not be going to transplantation or may not be able to be transplanted for various reasons. So there's been a lot, and I think the pattern continues to evolve with further refinement of the various strategies. One important area of research will be to sort out what is in fact the best and most promising treatment for a given patient. We still are not able to distinguish patients up front, certainly in adults, very well what the prognosis is. There are some patients who have an excellent prognosis and there are patients who don't. So developing markers for the risks that are reliable would certainly be very welcome and will be helpful in making treatment decisions, i.e. should this patient go as quickly as possible to a transplant, or should that patient have non-transplant, somewhat more, quote, conservative therapy. And as far as transplant is concerned, and we heard some of that today presented by Dr. Amy DeZern, is a matched donor really the best donor, HLA matched, or can we achieve similar, even better results if we use only what we call, as I said already, HLA haploidentical, half-matched donors? There may be some advantages in regards to the immunological response. That remains to be seen. And certainly, and maybe I should have mentioned that first, further efforts, hopefully successful efforts, at preventing this graft versus host disease, GVHD, and there is some progress there as well, because in patients who develop, it's a small proportion, but in patients who develop GVHD, that can significantly impact the quality of life due to the treatment they need, due to organ manifestations, lungs, skin, etc., that may impair their otherwise normal function. I think what has been very impressive and has moved the field along has been the tremendous collaboration. And the development of the Aplastic Anemia and MDS International Foundation is just another aspect of that in the, let's say, non-professional world, but in the world of support for patients where they made their commitment. And we do know that patients who have better support from in the non-medical aspects of their disease, support systems and so forth, and information in particular, where can I get information, how can I, etc., who are the people I should be in touch with. And that is where the foundation, I think, has had a tremendous impact. So it was a no-brainer, truly, to agree to serve on the advisory board. That's the start. And then as time went by, to extend on what your question was, certainly the foundation has been extremely supportive of what we have been doing. They supported, for example, our patient care conference at my center in Seattle every 2 years with logistically and so forth. Without their help, that would have been much more difficult. So to stay with the foundation, I think was of mutual benefit and again, a rewarding activity. We have organized patient conferences usually every 2 years, alternating with conferences of similar nature going on elsewhere for patients. And the thinking behind that was, still is, that really, firstly, patients want more information, want reliable information by experts, and experts were present as panelists and presenters at those meetings. And patients like to be involved in the decision-making process. So the better informed a patient is, the more meaningful is that participation of the patient, since you have someone in front of you when you have those consultations who you know has a certain knowledge, and maybe not all the details, that the expert should be aware of and should be competent to discuss, but really the overall picture, what is involved, what can I expect, what are the potential drawbacks, etc. So to have patients in an audience where they have an opportunity to talk to a number, not only local, but also other experts from elsewhere in the country or even abroad, has provided a tremendous resource for patients. Thank you for your congratulations.